Thank you so much, Dr. Yahya. Well, today, as we said, we're going to talk about how an optometrist will perform a full eye exam. And it's really hard for us to talk about the full eye exam in 30 minutes or even less. A full eye exam, and why did I bring this topic at this time of the year? Now with the new graduation of the new students that are graduating from the optometry schools in the kingdom, they're carrying an optometry doctorate degree, which is a great type of it's a doctorate degree that allows them or entitles them to start practicing more than refraction. So the name refractionist is something that we have to start getting rid of now, and you need to look more into the eye health because you are considered to be the primary eye care doctor. And this is what we're working on in the Saudi Association of Optometry, and we are working on the World Council of Optometry. This is one of the missions and one of the goals for all optometrists to be at this level. We know that optometry has a big diversity in the scope of practice worldwide. So in some countries, an optometrist is an eye doctor, and in some countries he's mainly like kind of optician. So these differences we're trying in the World Council of Optometry, we're trying to reduce those differences between the two names. Okay, so. Just to begin with, let's start with who is an optometry and who is an optometrist and what is optometry. Optometry is a healthcare profession that is autonomous, educated, and regulated, so it's licensed and registered by the Ministry of Health or any other health authorities. And optometrists are the primary healthcare practitioners of the eye and visual system who provide comprehensive eye and vision care, which includes refraction and dispensing. This is part of our job. Detection and diagnosis, and I put a little bit of emphasis on diagnosis and detection. Management of diseases in the eye, and rehabilitation of conditions of the visual system. This definition for the optometry is listed in the World Council of Optometry website and the World Health Organization, which is the WCO is under the umbrella of the World Health Organization. When you are starting an eye exam, the eye exam consists of two parts. First, you need the part that you collect the data. Okay, you need to know what is this case, what kind of patient you're dealing with. So that starts from collecting the case history, the chief complaint, and doing the entrance test. What is the entrance test? It's the vision, taking the glasses, measuring the glasses, the cover test, the EOMs, the pupils, peripheral visual field, everything that will collect as much data as you go on. I know that some people will tell you, why do I have to go through all this list? Why not do it if I need it? Well, there are two ways. In the beginning, I advise you just to go on and do all these tests. First, it's a good practice for you. Second, it will really give you a very good idea of what kind of patients you're dealing with. And you'll be surprised that by just doing a cover test, you will be surprised that the patient have something hidden that is not showing in the regular cases. Refraction is a big part, of course, in any eye exam, because you always need to know what is the best corrected vision for the patient. Measuring pressures, it's very essential, and we're going to talk more about it as we go on. The other part is actually checking the eye health. So, and you do this by doing slit lamp. And you need to master doing slit lamp. It's something, a part that has to be in your clinic, not just a tool that is collecting dust and you're not using it anymore if you're not doing contact lenses. No, it's a slit lamp. It's something that you should perform in every single patient to look for if there is any abnormalities. And the slit lamp, you can check the anterior segment of the eye and the posterior segment of the eye. We're going to explain more about it. So, in taking the case history, of course, there's like the general information that you need to collect. However, there is the general health part that you need to ask the patient, or sometimes in every clinic, this sheet that has all the information about the patient, and it asks about any major diseases. And what I emphasize on the vascular diseases, especially because they have ocular involvement. So we're talking about diabetes, hypertension, cholesterol. Yeah, that's, I think, better. Cholesterol, Samini, it's not working. It's working? Okay, أنا مسامع جل. So diabetes, hypertension, cholesterol, all these big diseases, just know if the patient has any of them. If they're using any systemic medication, please get familiar with some of the major, I'm not telling you know every single systemic medication, but there are a few things that you need to know, especially read about the ones that has ocular side effects. We know that some systemic medication have ocular side effects, and I listed some of them, but just remember, for example, steroids, they do have a definite effect on the eyes, starting from cataracts and increasing the intraocular pressure and stuff like this. This is one of the medication that I see a lot, the Accutane. It's an acne medication. And many patients nowadays, many dermatologists, they prescribe this type of medication. And I'm talking from personal experience. It causes very severe dry eyes. So you need to know that before you start prescribing contact lenses for the patients, or just, to know why the patient is suffering from this severe dry eyes. Talk about some drug allergies. It's very important to know them, especially the two big ones, the sulfa and the penicillin. Now the chief complaint. Okay, so you have to understand why the problem, why the patient is here. And you can have a very good idea about what could be the diagnosis just from the patient's words. This is the most common, complaints that you might hear. And remember, with every single complaint, there could be many differential diagnoses for each one. So, for example, if a patient tells you, "I can't see it near," it could be just as simple as presbyopia, or it could be macular degeneration, right? So there are many differential diagnoses. If the patient tells you, "My eyes are watery, red, dry," all of these things that you need to check for the eye health. If a patient has headaches, we have a lot of patients come, they have headaches, right? So we need to know if it's eye-related or not. So when you do this by doing your refraction, your sacral refraction, and all of this. So any of this, so for example, I have transient vision loss. A transient vision loss is a big thing. Nobody should lose their vision for even seconds, okay? So this is something that should be taken seriously. My vision is washed out. I can't see colors very well. I see halos around lights. Halos around lights could be corneal edema, could be keratoconus, could be anything in the eye. My eyes hurt when I look at the light. Could be uveitis, could be anything. So just remember what kind of complaint you're dealing with and know their differential diagnoses. Always you have to document if the patient ever had any eye surgery, and if he's taking any ocular medication. Just to make it easy on you, it's very smart to have a form that lists all these tests together, because it will remind you, I need to do cover tests, I need to do pressures, I need to do this, I need to do this, so you can just follow the sequence of the exam and not forgetting anything. All right, let's start with the entrance test that we talked about. So we need VA. VA is something that we should, any patient needs to come in every single visit, you have to take VA. Do not depend on the previous VAs. Never. Every single time he comes to your clinic needs to be taken. Measure his previous glasses, because that will influence your decision in what to prescribe this time. Cover test. Why do I love cover test? I do it on every new patient, because it really helps me a lot when I decide to prescribe glasses. Now, if a patient, let's say the patient is normal, he doesn't have any tropias, but he has phorias. Phorias are very annoying. Phorias can really affect your reading time, your reading abilities, and it's just going to give you a hard time. So, for example, if I discovered that the patient somehow has exophoria, so I'll try to push as much minus as possible and give least plus as possible. On the other hand, if the patient has any esophoria, I will try to push as much plus as possible and reduce the minus as much as I can without affecting vision. And definitely remember the two types. So you do cover and uncover to check if there is any strabismus, and then you do the alternating cover test to check if there is any phorias. Please do it at distance and near, not just at distance. All right, EOMs is also very important. You need to know how the muscles are working together, and just record them. Okay, there is a very nice test. Who does Amsler grids? Okay, Amsler grid is a very important test, and it's underestimated a little bit. Why? Because, you know, it's just you can carry it in your pocket. They always distribute it, like when you have those knee charts. If you look at the back of this knee chart, there's an Amsler grid. So basically, what you need to know, so why are we doing this test? We're doing it to check for the macular health. And you'll be surprised that sometimes early changes of macular problems, this test starts to pick it up before even the vision is affected. So the patient might be seeing 20/20, but when you do Amsler grid, he might have some problems there. So checking for central vision, you ask the patient to look in the center and ask him, do you see the four corners of the square? And then look at the lines, let them describe the line for you. Are they straight? Is there any distortion, any twirling, any uneven lines? All of this needs to be asked. Sometimes the patient would tell you, yeah, they are twisted, the lines are not straight. Sometimes they tell you, well, I see it, but there is like kind of missing lines in here and here. And this is where the scotomas might lie. Refraction, I'm not going to spend a lot of time on refraction. Everybody knows how to do refraction. The only thing I'm going to emphasize on is please do retinoscopy on every patient. Why? I do retinoscopy not just to know the refractive error. Of course to know the refractive error, because sometimes, you know how patients, they manipulate us when we're doing refraction. They will take you all around the clock dial of the GCC. But if you do retinoscopy, you know what you're seeing and you know what you're prescribing. You don't depend on the patient's subjective exam a lot. What else? Refraction, retinoscopy tells you if there is any irregularities in the cornea. So you see scissoring motions, if there's any corneal scar or keratoconus. If you perform retinoscopy and you see dark spots, or you see dull reflex, it's probably cataracts, you know. If you see two different refractive errors, could be within the pupil, then it's probably subluxated lens. If there is no view whatsoever, if you shine the light and you see nothing, this problem could be either mature cataract or maybe the patient has some kind of vitreous hemorrhage because something is really blocking the view and light cannot enter the eye anymore. And so on and so forth. Pressures are very important and essential, and it has to be as part of your routine to check for the intraocular pressure. Remember, IOP is one of the risk factors for glaucoma. We know glaucoma is a neurological disease of the optic nerve, right? And sometimes people might have normal pressures and yet they have glaucoma. But at least for you, you should know if this patient has an increased intraocular pressure, especially when you're dealing with a geriatric population. You know, we've always, like, by chance, by coincidence, I looked at the pressures and I saw them, they're a bit high. So I send the patient for visual fields, for OCT, and you find that the patient's starting to have some kind of visual field defects. So definitely those patients need to be managed immediately. Remember, the IOP can be measured by any mean, whether it's an applanation Goldman, tonometry, air puff, tonopen, or the aura. Any of these will tell you a really good idea about the pressures. Now, when it comes to slit lamp, as I said, you need to master it. You need to understand how you're focusing your microscope and your light source. So, for example, you should start with this sequence. You start from lids and lashes, conjunctiva. It has to, your light will use the parallel pipette with low magnification in the lids and lashes and conjunctiva. When you want to see more details, you increase the magnification and you narrow your slit beam to focus on the structure. There is a very important thing I need to focus on, which is the von Herrick technique. What is the von Herrick technique? It's basically, you're checking the anterior chamber angle, okay? So let's look at this. Sometimes you decide to dilate the patient. You need to do cyclorefraction, you want to take a look inside the eye, whatever. Before you do this, and especially again, patients, elderly patients, you have to just bring your slit lamp on a very slit beam, small beam, and you just need to focus it on the corner or at the limbal area, okay, of the cornea. And then you just need to look at this difference between the corneal reflection and the iris reflection, and this is basically your anterior chamber angle. If the light or the space between those two was narrow, that means the iris is very close to the cornea, so that you have a narrow angle. So you need to be careful before you dilate those patients. You need to know if it's okay, because you don't want to close the angle. You don't want to block the drainage of the aqueous humor. So please do this test at least before you dilate. Now, when we're looking at lids and lashes has to be clear, smooth, no flaky or anything at the base of the lashes. What else do we need to look at the lids? We need to look at the meibomian glands orifices, the opening. We need to look at the secretion of those meibomian glands. So when we press on those meibomian glands, we need to see a clear liquid coming out, a clear oil coming out of those things. Any clogged meibomian glands will look like this, okay? And eventually, if this condition persists like this, you might end up with a sty and chalazion, and the patient really ends up, it's going to be really bad, because those can get inflamed and, you know, starting to have those nodules, and it's painful. So definitely you need to work on this with those patients by using warm compresses, massaging the areas, opening the orifices of the meibomian glands. Otherwise, if the patient really have a chronic problem and he keeps on having those ties, he's gonna end up and like going to the doctor and having an incision, and they scoop out this pus and cauterize it. So instead of like reaching to this level, always make sure your eyelid margins are clean and clear. Blepharitis is one of the other things that you need to really focus on, because blepharitis is one of the contraindications when you're prescribing contact lenses. You don't want to put a contact lens in a patient eye with blepharitis. You don't want to this patient to go into cataract surgery with blepharitis, because this is bacteria. This is staph bacteria, and it can get inside the eye and cause problems. So definitely lid hygiene and cleaning of the eyelids and treatment of the blepharitis is very important. So this is what we're looking for. What else we're looking for in the eyelids? You as an optometrist, you're sitting in your chair and you have a good eye. Sometimes a patient would come with something that looks like this. Well, it's just a pimple, or maybe it's just like whatever, kiss duhni, whatever. It's something like they don't know. But this is tumors. This is eyelid tumors. This is something, if you see anything that is pearly and scaly and has some nourishing blood vessels through it, this is cancer, and definitely needs to be treated, needs to be referred immediately. What else? Any pigmentation around the eyelid that has like different pigments here and there. This is malignant melanoma. Sometimes a patient would come with a scary looking thing on his eye, but you have no idea what is this. It could be as benign as just a nevus, okay? But anyways, just refer it whenever you see something not normal. So anything suspicious that looks like this, a nodule, something that it has different color, a rough texture, ulceration, pearly edges, always refer. Definitely do not. You can save a patient's life by just noticing those things. What else you need? Conjunctiva. We have conjunctiva. We have the palpebral conjunctiva and the bulbar conjunctiva. And the conjunctiva is a vascular tissue, so any inflammatory reaction, anything goes wrong in the eye, it will translate in vasodilation. It will translate in redness. Okay, so whether it's a bacteria, viral, fungal, allergens, anything will give you dilation of the blood vessels and redness. So this is or papillae and follicles in the conjunctiva, in the palpebral conjunctiva. So if a patient comes and telling you, my eyes are very itchy, and the more I itch them, the more it gets itchy. You know, it doesn't release them. This is mainly allergic conjunctivitis. This is allergy. The same red eye or similar red eye, but with a mucopurulent discharge like this, this is a bacterial conjunctivitis and definitely needs to be treated. Patient who has this like crying watery eyes with a thick with a thick serous discharge is a viral conjunctivitis. And if you avert the lid and look inside the, like underneath the lid, and you see papillae that looks like this, and they're pretty giant, this is giant papillary conjunctivitis. It's very, related, or like it's very highly associated with vernal kind of keratoconjunctivitis, and sometimes you see it with contact lenses. However, how's the time? Are we still good with time? Time? Are we good with time? Okay, so yeah, it's associated sometimes with contact lenses. However, that's in like, we haven't really seen GPCs with contact lenses for a pretty good long time, because the material of the contact lenses has changed dramatically. They are softer, they're low modulus now, not like before. But definitely one of the hallmark for GPC with a contact lens wearer is discomfort. What else we see in the conjunctiva? We can see subconjunctival hemorrhage. It looks scary, but you definitely can assure the patient that it's absolutely normal. It's just like a bruise in the eye. Pinguicula, we see pinguiculas. Sometimes you get to see spots in the eye. And the patient would come to you saying that I have a gray spot in my eye. Well, most of the time it's normal, but again, if you suspect anything, even in the conjunctiva, you can get cancer. So you can definitely refer it. Sometimes some darkly pigmented or dark-skinned patients, they have something called ocular melanosis. That's basically a lot of like darkness around their eye, but this is normal also. Now let's go to cornea. Cornea is a transparent, round, highly innervated tissue, which is the window of the eye. So it has to be clear, it has to be round, and when you stain it, there shouldn't be high fluorescent staining, okay? It just has to have a smooth staining. What are we looking for in the cornea? In the cornea, when we have anything that is, as I said, it's a transparent tissue. Transparent tissue, there shouldn't be any blood vessels. So if you see any blood vessels growing into the cornea, you need to know why. Sometimes it could be, contact lens related. You need to check what kind of contact lens you're using with those patients. And it could be worse than that. Anything that goes into the cornea is not normal. Corneal abrasion, keratoconus. So, okay, one of the things that I wanted to emphasize on, and I have a story about this. Once I had a patient who had corneal transplant in one eye, and in the other eye he was following up with me for contact lens fitting, okay? So the patient came for his follow-up appointment, and I was checking on the contact lens, and everything looks fine, normal, happy, the patient's happy. But then I saw that his left eye, which is the grafted eye, is kind of red, and he has a droopy lid. And so I took my slit lamp and I took a look at it, and guess what? I started seeing some subepithelial infiltrates. This is white blood cells migrating into the cornea. And this is one of the signs of graft rejection. The patient's starting to have new vascularization growing into the cornea. And I freaked out, and I called his doctor immediately, and I told him that we have those signs in this patient's cornea. He came, he checked it, and it was early signs of graft rejection. And guess why? The patient just decided to stop his medication. He stopped using the Pret Forte. He just decided, oh, I don't need them anymore, I feel fine. And this is when he started having those graft rejections. So if you're working in an ophthalmology practice and you see a lot of those patients, sometimes the patient doesn't have an appointment or a close appointment with the doctor, but he has appointment with you. Just make sure you don't see any of those signs for transplanted patient. And definitely saving a graft is a precious thing. So corneal abrasion, also sometimes a patient might come to you saying having pain. Pain in the eye is not an easy thing. When the patient tells you my eye hurt is not an easy thing you should not ignore. Check all the cornea, stain it, put fluorescein. Sometimes a metal piece can get into the cornea and stay there, okay, and keep on having those irritation and causes like rust ring. We call it rust ring around the cornea. Usually patients with a small abrasion, depending on the size of the abrasion, they do have moderate pain, tearing, mild hyperemia. So you definitely need to look into the cornea, when you're doing this. Now, this is abrasion. This is easy, simple. What is the big one? The ulcers. Corneal ulcers are very scary. Could be bacterial, could be herpetic, like this one, which has a dendritic kind of ulceration. Could be fungal, anything, and it's a serious, it's an emergency case, something that you should not ignore. If you see redness, pain, tearing, and a huge staining in the eye, it's an emergency referral, nothing that you can just keep in your chair. Definitely send it to ophthalmology right away. Okay, now when it comes to lens, when we're checking, this is still we're using our slit lamp. Lens has, we need to look at cataracts. This is cortical cataracts. Cortical cataracts, it looks like this. They have spokes like from the edges. And the thing that you also need to focus on, it has hyperopic shifts. Sometimes if it gets really into the center of the lens, it has hyperopic shift to it. Nuclear sclerosis, it's the opacification in the center of the lens, and it's associated with myopic shift. So I remember seeing patients who have been using -3 all their life, and out of a sudden they're -5, and he's 60. So what could be the reason? It is most likely cataracts. So posterior subcapsular cataract, sometimes we see it with younger patients, especially patients on steroids. They can have it. The other differentiation between posterior subcapsular cataract, there's something called posterior subcapsular opacity, which is a secondary cataract. There is some kind of like proliferation of epithelial cells that grow into the posterior capsule and cause this opacification. And it's not scary, but the patient will tell you, I used to see very well after the cataract surgery, and suddenly my vision has changed. And this is basically, could be this one, especially if you take your retinoscopy, you won't be seeing clear image. And the treatment is very simple. Send it for YAG laser capsulotomy. Now, this is the part when we go inside the eye, the fundus. Here, if you really want to do it on your own, you need to really get used to using the ophthalmic lenses or the auxiliary lenses, which is a very high magnification lenses to check the posterior pole. So we look at the optic nerve and the macula. And remember, with those lenses, everything you see is inverted and reversed. So everything is the opposite. Okay? Okay. So just remember, this is a healthy fundus. Look for any diabetic retinopathy, starting by signs of dots and blots, age-related macular degeneration, any changes in the macula. Remember when we talked about Amsler grid? If you really couldn't go into this, you can do your Amsler grid at least. Retinitis pigmentosa, optic nerve, and that's it. So if you need to really look inside the eye, just get used to using those lenses. Or if you're very lucky to work in a sophisticated clinic and have fundus photos, please do it. Just remember one thing at the end. Let me just finish up. Detecting early diseases is you're saving a lot of misery for the patient. If you detect a child with high anisometropia and you prescribe the correct prescription, you're saving the patient from amblyopia. If you discover glaucoma early, you save the patient's vision, and so on and so forth. Just, I have a nice thing I read online is that, you know, with those new robots thing that's coming on the market, they're telling you, do you think a robot will ever take your job? And on a survey, they said, if you're an optometrist, the chance for a robot to take your job is only 14%. So don't worry, you're still going to have a job. And thank you so much.
Okay, assalamu alaikum, everybody. Good morning. So before I start my presentation, I would like to talk more about me. So I hold a master's degree in orthoptics from Sydney University, Australia. I am a certified dyslexic therapist and a certified Chromagen lens dispenser since 12 years. Okay, so I'll be talking about color vision and you know, basics first, and then I'm going to talk about case studies, treatment. I have the lenses with me if anyone wants to have a look at it, and you know, If anyone has a color vision problem, you're welcome to come to me and we can, try it on. We're supposed to have a live patient, a real patient, but unfortunately he didn't come. So best view. Yeah. Okay. So as I said, I'll start with the anatomy of the retina, going to the color vision definitions, anomalies, epidemiology, and some research, and then the management options and case studies. So just basic anatomy of the retina, as we all know that the retina has 10 layers, and I'll just focus on the cones around. So when the light goes in the eye, then it's translated to the brain, we can see things and we can see colors. The retina has a photoreceptor layer, and the photoreceptor we have the cones and the rods. The cones are around 7 million. They are responsible for our vision in daytime and also for us to detect colors. And it's more sensitive than the rods. The rods is around 130 million. And it's responsible for our night vision and also our kinetic vision, and which is like movement, like when we're at the dark, we can still see shadows and we can still see moving objects, and it's less sensitive than the cones. Okay, so the cone has 3 basic parts or colors, let's say, the red being the longest wavelength, and then we have the green, and then we have the blue, okay, and each one of them has a different wavelength and a different mechanism in absorption of the eye, how it's absorption of the eye of the same color. When we talk about color vision, so we see colors, but then if we go in details, we also see hue and then intensity and saturation. So hue is just denotes the location in the light spectrum itself, and then the intensity is how bright the color is to our eyes, and we have the saturation, which how much white light is mixed with the pure hue. This is just basic. And normal color vision is called trichromacy. Okay, so what's color blindness? A lot of patients come to me and they say, okay, am I going to go blind? No, okay, so it's different, but it's just called color blindness, especially in Arabic, ama alwan. So everybody, like a lot of people, they just come to us and they just go, okay, are we going blind or no? So we should call it color deficiency, but in Arabic it's called color blindness, okay? So it's just a vision deficiency that inhibits the perception of colors. And colorblind people perceive a narrower color spectrum compared to those with normal color vision. And the difficulties can be very mild to severe. Like some people come to me and say, okay, I can see colors, but I cannot see the colors when they're mixed together. Okay, so they actually, I'll just keep talking about cases who came to me. I've seen around 60 or 50 people since my 12 years of experience who suffer from color deficiency. And the term, again, color blindness, that doesn't mean that the person is blind. So they actually see colors, but the way they see it, or the way they interpret, the eye and the brain interprets the color is different. Okay? Okay, I just came through these 3 studies talking about color vision deficiency, and one was in Riyadh in 1996, which shows a low prevalence of color blindness in our country, which is okay, good. And in Jordan, apparently, it showed a high prevalence, and that study was only in 2001. And monochromatic color vision deficiency, which means that only one cone is working and one cone is active, is very, very rare. And that was a study in the UK in 2001 showing 1 in 30,000 cases. So it's very, the monochromatic color vision deficiency is very rare. Okay, so the most common hereditary color vision defect is the red-green deficiency. A lot of people, they come and just say, I cannot see the red, or I cannot see the green, or the red is seen as brown, the green is seen as purple sometimes, okay, or bluish. As we all know, that affects males more than females, okay, going from 8% to 0.5% in females. And again, the gene for the red-green color blindness is X-linked recessive, so it's a recessive gene. And failure of the blue, like the blue color, the blue-yellow color deficiency is very rare, and it happens usually with acquired color vision defects, mainly in very advanced glaucoma patients. Okay, so I'm going to talk a little bit more about the pathology, going from hereditary and acquired, and then partial and complete color vision deficiency. Okay, so again, hereditary or congenital, it affects males more than females. It is red-green, and apparently there was a study talking about color vision deficiency in females, and it's 2 to 3%. And I personally saw one female who was suffering from color vision, and I'm going to deficiency. I'm going to talk about her. The Chromagen lenses really, really changed her life. Okay, and for a male to be colorblind, as you know, that his gene is an X chromosome, and for a female to be colorblind, it must be present on both X chromosomes. And this is just an example. So the father is not colorblind, and the mom is colorblind, and then the kids. As you can see, the boys, they are colorblind, but then the girls are just carriers. Okay? Okay. So congenital color vision defect, it comes with the cone rod dystrophies, with any neurological or retinal atrophies or dystrophies. And these are my patients. I've seen them last year. They had cone rod dystrophy. And literally, when they walk in the sun or in normal brightness, they cannot open their eyes at all. They are low vision patients, and they have very, very difficulty opening even a little bit, a small part of their eyes. But then, as you can see, when they wore Chromagen lenses, the mom was amazed. They went in the sun. They can, be normal children, even if they are low vision kids. So as you can see, they open their eyes now, and they are very, very happy. Well, they don't seem happy, but they are happy with their glasses. Okay. Acquired color vision defect. So we have some chronic illnesses, they say. It's an Alzheimer patient, glaucoma, which is very rare, MS, and I'm going to talk about it more. They don't really lose their color vision. It comes back after the attack, but of course, there will be still a difference between both eyes in how they see the colors. Accidents and strokes, medications, psychological or psychiatry medications, and some industrial like chemicals or carbon monoxide. And age, well, it's not really loss of color vision, but like people who are over 60, they just have reduced of the hue and the saturation of the colors. Okay, and then we'll talk about the partial. So an example is optic neuritis. So as we all know, when there's an attack of optic neuritis on one of the eyes, the first sign is wash out colors. The patient will come and say, I have washed out colors, and then the vision reduced. So that's a really big attack. So the color, the color is washed out or reduced before the vision, and that's an attack of one of the eyes in optic neuritis. There's other symptoms, for example, metamorphopsia, which is seeing the straight lines as zigzags. This is also a macular problem, which also can affect like color vision as well. But then they say that one of the studies was talking about macular diseases. They tend to produce like the blue-yellow color vision deficiency, not the red-green. And complete, which is due to alcohol and drugs. And I've actually seen a case in Australia. She was a 35-year-old female who woke up in the morning. She was an alcoholic. She woke up in the morning and she literally cannot see colors. Everything was black and white. So this is toxic optic neuropathy. Okay, I've really seen this case, and I really felt sorry for her, to be honest. Okay, so what are the symptoms? A lot of people ask me, okay, what are the symptoms? Like, how do I know that I'm color deficient? So all the patients that I've seen, they just come to me and say, I failed Ishehara, especially the male. They finish school, they want to go to universities, or they finish universities and want to go, want to find a job or anything. They just go, I never ever realized that I cannot see colors, except when I went, and did the test, the basic test, I just failed Ishehara. So I'm okay. I mean, I'm living my life and nothing, it doesn't affect males as, females. But that lady that I talked to, it really affected her life. She says, I cannot see the color of the food when it's cooked. I cannot know what kind of allergies my kids is having. I don't know, like the drugs when she was, when they were kids, for her kids, she didn't really notice, if it's bleeding or, so she had difficulty. Of course, she couldn't put any makeup. She loved to paint. When she was little, she stopped painting, okay, for 20 years. So it affected her life. Okay, and there are other symptoms or other signs showing with the color vision deficiency, which are nystagmus, low vision patients. Again, symptoms of chondral dystrophies, like the patient cannot, tolerate like extremely excessive photophobia, cannot tolerate the light. Sometimes they say, I see shadows, like an MS. Okay, so we're going now to the classification of color vision defects. Okay, so trichromacy means that the three cones are present in the eye, red, green, and blue. The eye is absorbing them, the patient is seeing everything, everything is normal. When one of these cones is a little bit out of alignment, it's called anomalous trichomats. And we have the blues, reds, and greens, and I'm going to show you. By the way, the pictures are just simulation. It's very difficult to understand what the patient sees, how the patient sees colors. So if he just says, okay, I can see the red as brown, because I have normal color vision, I say, okay, I understand. But sometimes he just goes, okay, I don't know what the color is. So it's really, really difficult. I got these pictures from the internet, just, showing, giving us an idea, I guess. So protonomally, that means there is an anomalous trichomat, which is the red one. So he's seeing properly, everything is okay. And he can see, for example, shmag, he can see it as red when it's on your head, but then when it's like combined with different things, so for example, apples or putting a lot of reds together, he cannot really see the red, okay? So when it's only separate, he can see that this thing is red, okay? That's for the trichromacy. The deuteronomy, which is problem or anomalous in green, okay, and most of them actually, they don't see red. They tell me that it's kind of brownish as well. So the red, sometimes it's brownish or sometimes purpley, and the green is sometimes brownish. That's what they tell me. Trichonomaly, which is a problem in blue, and I haven't really seen any patient. I don't know what he sees, to be honest. Okay, dichromacy. So 3 cones are present. 1 cone is not working, and the other 2 is totally normal. Again, we have, and it's called anopia. So anopia, it means disturbance or absence, okay? So we have, this is the normal, and we have protanopia, problem with the red cone, green cone, and blue cone. And again, this is just simulation. We don't really know what that person sees. Okay? Monochromacy. So 3 cones, only 1 is working, okay? The other 2 is not working, and they say, I didn't find any pictures on monochromacy, but they say that everything is 1 color. So everything is either red or either green or either blue, but it's not really red, green, and blue. Okay, so it's only 1 color. He cannot really identify colors. And achromacy, again, it is very rare. As I told you, the one that, the lady who was alcoholic, or if there's other symptoms, like the retina has other problems like neuropathies or congenital retinal diseases, or so it's very rare, and it's associated with other symptoms. So usually a normal person, like if the eye is normal and it's working and everything is fine, it's just color vision deficiency. So the person will just say, okay, I cannot see colors. But if it's associated with other diseases, that means the retina in a whole, like as a structure, it's all disrupted, and it's it is a bigger problem. So color vision is not a big deal if this patient had other problems. Okay, so color vision tests. So everybody knows Ishehara, of course. Okay, it's called pseudo-isochromatic plates. We have the Farnsworth-Munsell. Anybody use this test? Anybody? Dr. Khalid, okay. Actually, I use the 15 because the 100 takes an hour and a half. So no way. Okay, so I use the 15. And then we have the red saturation test. This is a test that I've learned in Australia. It's a very quick screening test. So I'll talk about it later. And we have also the City University. I also experienced, or I used it in Australia, but here we don't use it. So I'm not going to talk about it in details, okay? So Ishehara. This is our lovely scientist. He's a Japanese ophthalmologist. His name is Shunbo Ishehara. So everybody knows Ishehara. I'm just going to go through it really quickly. It comes in books of 15 plates, 24, 36, and 38. It's usually used to diagnose congenital red-green deficiency, and it's also a very quick screening test. and it has different plates, and I'm going to talk about the plates later. Just quickly going through recording. So recording is really important, just to show how many, like what test did you use, how many plates did you use, okay, and it's very easy. You just go, 24 out of 24, the book is 24, and if the patient has a problem, you can just say, okay, 0 out of 23, which is a red-green color blindness, and it shows, it is like 90% red-green, okay, especially if I'll show you the plates that is used for red-green, and you can just tell, it's very easy. So this first plate, it's always 12, it's always like a grayish and orange, these two, so everybody know that this is a screening. Even the colorblind person will read it, okay, even if he doesn't see colors. And then we have, okay, so going to Ishehara plates, we have, first of all, it's called the transformation plates. So the transformation, if you go through the book is numbered 1, 2, 3, 4, 5. So it's plates 2 to 7, and as you can see, okay, it is almost 3 colors or 4 colors. So the green is only 2 colors, okay, or 3, and it's not that difficult because the green is really popping out, okay, and it's not very you don't have a lot of colors in this plate. But apparently, patients who suffer from color vision problems or color vision deficiencies will not see this number. He will see it either 2 or 0 or 8, and these are the responses that I got from my patients throughout the years. Disappearing digit plate, as you can see, it got a little bit more difficult, okay, especially putting like a very bright color in the background, and then the greens are a little bit less contrast or less hue or saturation. Okay, so it is difficult, and the patient really cannot, who's suffering from the problem, either sees only the one, which is, I don't know why actually, maybe because it's easier to read, or just say nothing, I cannot see anything. Okay, and then the qualitative plates, okay, which are, these plates are the numbers from 16 to 23, and then they just, these are the plates that where you identify the deuteron from the proton. And then we have the hidden plate. So hidden plate, it shows the acquired from the congenital. And also, by the way, I can give you a tip that this plate or this part, you can use it for malingering patients as well. I've used it on malingering patients, and it works really, really well. Okay, so it's just something that I just thought about, and I'm using it now in my clinic. So I just opened the book on this page. Okay, when I do near vision tests on malingering patients, and it really, really works, okay? So you can use it for that. Okay, these are just examples. Okay, so what number is this? 20? 8 or 9? Okay, who's saying 8 should come to me, okay? So it's 29. It's 29, and the patient will read it 10. And then this one? 5? 5? The men, not the ladies. 5? We need him, صح? Yeah, we need him, okay? So, 3? Oh, no, you have trouble. Okay? This one? 42. So usually the patient will see the red, okay? So that he will say 4. And this one? Sure? 100%? Gentlemen? Oh, they're interested. You're cheating, okay? So they should read it. Yeah, exactly, you can see. Okay, and then, sorry. How about this one? 97, okay? And I don't know why, they just see one number, okay? So they just see the 9, okay? So these are just responses from my patients. Okay, we have Ishehara for kids. So, mashallah, our kids are really smart. I use like the regular Ishehara for kids who are, 5 to 6, who knows the numbers. Of course, we have to do Ishehara monocularly in some cases, but I usually, if the patient is young and no ocular problems, I usually do it binocularly. Okay, and these are just examples of Ishehara. Okay, so everybody asks, when do we say it's normal or abnormal? Okay, if the patient had 3 mistakes per eye, that's okay. If the patient had 6 mistakes per eye, that's a problem, okay? So it doesn't matter which plates, like what numbers are the plates, the book, if it's 15, 38, 36, it doesn't matter. So if it's 6 mistakes per eye, that means the patient has color deficiency, okay, in a way. طيب. the Farnsworth-Munsell, as you can see, okay, this is an example. So these are like colored, it's like a ruler that has different colored caps. And we have 2 fixed caps at the beginning and the ending of each ruler. Okay, and then the patient is just supposed to organize the color. So it's better to put it on a very clean and a very, bright background. So it's either white or black. So in Australia, they have like a big black table, and we can put it on it. Even Ishehara, by the way. And in Australia, they use gloves when they do Ishehara for the patient and the examiner. I don't know why. But, they're really, really organized in this thing, okay? Okay, and this is how we record it. So as you can see, the test, it's just the order of the test. So 1, 2, 3, 4. So each cap has a number. Okay, and then what you do is, as an examiner, you just write down what the patient will tell you. So after you finish, you just close it and then you flip it and then you read the numbers. Okay, so it's really organized and very easy to do. And then you just, draw your graph, and then it shows here an example of normal. If the patient has protan, deutanomaly, tretanomaly, and rod monochromacy. Okay, so this is all, you can just print it out from the internet. It's all available. Okay, red saturation. So I used this test in when we were screening university students, male and female. So I just used it very quickly, and you can also use it in neuroclinic. When the patient has optic neuritis, so sometimes it's a really quick test. So you just close one eye, you show the patient the any medication, like whatever, any atropine or anything that has a red bottle, and you ask the patient, okay, this eye sees, you go to the normal eye first if you know there's an abnormal eye. So you just go, okay, this eye sees the red color 100%, how about this eye? He goes, okay, 70, 30, 20, 80, okay? Just to have a quick idea on, okay, there is a problem. We use this in neurological patients, okay, like neuro-ophthalmology. And you write down what the patient can see. Okay. So how does color vision affect our lives? In children, I'm almost done. Okay. I'll do the management then. Well, anyway, okay. I need extra time, shwaya. Okay, so how does it affect our lives? I was just talking about one study. So for male, or it's very common, the jobs. So military, Air Force. In Aramco, I have a lot of people coming from Aramco. They're very, very strict. They don't accept anyone who has color blindness. I don't know why. So any person who is working in the lab and whatever. There is a study talking about dyslexia, because I'm involved in with dyslexic children. So they just said that any child who has problems identifying colors, they're not colorblind, okay, but they have problems identifying colors, will also have dyslexia, okay? And I found it in only 2 or 3 cases. Okay, so how do we, what is the cure? What is the management? So there's no cure. If there's an underlying cause, like optic neuritis or whatever, you cure the cause itself. But there are studies talking about color filters. They are called Chromagen lenses. And we have in the internet, we have so many fake lenses. One of them is Inchrome. Has anybody heard about Inchrome? There was a video going through WhatsApp. It's like a black lenses, and then the child or the dad, that I can't remember, just sees colors and starts crying and screaming, and come on, give me a break. This is not real, okay? Definitely this is not real, trust me. Okay, so the Chromagen lenses, they are FDA approved since 2000, okay? They are بالعربي براعة اختراع, okay? So it's a really proper lenses. Do not prescribe your patients cheap lenses, okay? And agree on cheap lenses because they don't work. So Chromagen lenses, it's a system of 8 haploscopic filters, as you can see. And we use the ones that are high wavelength. So the pink, magenta, red, orange, and yellow. Yellow can be used in both dyslexia and color vision. And these are the ones that I use for dyslexia or Arlen syndrome. Okay. As you can see, I told you, it's a Millennium product, okay, in the United Kingdom since 2001, and they are FDA approved in that year as well. So you usually put it on the non-dominant eye first, and then you see if the patient responds, and then you put it on the other eye. Again, I have the lenses with me if you want to have a look. And these are the studies, okay? So counter and nasal, in 1990. This is the company or the main or the mother company who produces the lenses. They are very, very strict. They only have one representative in the kingdom. Like in any country, okay, or any region, there should be one representative. I renewed my certificate with them last year, at the end of last year. Okay, so they are the people who found, or the founders of Chromagen lenses. We had another study, which is Dr. Harris. He's also a psychologist, working with colored filters with dyslexic children. And then there was a study in 1998, and then in 1997, and then there was a study by an optometrist. Her name is Kawthar Al-Qabbani. In 2005, she did her graduation proposal talking about Chromagen lenses, and she did like a small study in university students. And I did a lot of studies, but not published, too bad. And I have a lot of surveys about Chromagen lenses. As I said, I've been working with them since 2006. Yeah. Okay, so just quickly going through that means I cannot talk about the cases. Okay, I'll talk about them really quickly. So this is our female case. She's a mother of 6 kids, okay? She's 45 years old, came to me. She heard about me through Twitter, so she came to me. And she said, I cannot see colors. I've never seen colors. I've never enjoyed colors, so please help me, okay? Her vision is okay, as you can see. She's only presbyopic, no problems. And her son, one of her kids, so she had 3 boys and 3 girls. One of her boys also has color deficiency. So I just want to quickly show you the results. So with Chromagen lenses, before Chromagen lenses, 0 out of 38. She cannot see Ishehara at all. And with Chromagen lenses, she can see, as you can see, almost full, okay? And we have Chromagen lenses in glasses and in contact lenses. The contact lenses, it's just 8.5 base curve, 14 millimeter diopters, and as you can see that the color is at the center of the pupil, so cosmetically it's also good because men, they refuse, to wear pink glasses, so I just give them contact lenses. And this is what she saw before and then after. She actually sent me something similar, okay? The other case, as I showed you, so these kids, they have Conrad dystrophy, and they have very poor vision, 200 over 400, with nystagmus and severe photophobia. And this really, I was so impressed, so amazed and so happy to help these kids, because imagine 11-year-old and a 9-year-old, they're always home. They never go to parks, they never go to the beach because they cannot open their eyes in the sun. And their lives are almost normal now, okay? So I was so happy to help them. So I'm done. Yeah, I guess I'm done. Any questions? We'll read the questions later. Yeah.
Assalamu alaikum. I am Baya Masoudi, a second-year medical student at Al-Qura University. I present our research about the prevalence of color blindness among health track preparatory year students at Al-Qura University. So first, what is color blindness? It is inability to distinguish between certain colors. It results from the absence of a color-sensitive pigment in the cone cells of the retina. There are many different causes, genetic and acquired. Mostly it is genetic. It constitutes a significant handicap in daily life. Health professionals who have color vision deficiency have some difficulties in recognition certain color of the body changes. For example, cyanosis. Also dealing with body fluids, urine sample, blood sample, vomitus, sputum. Also it may affect their ophthalmoscopic and otoscopic examination. In a study in the UK showed that 10% of histopathologists and medical laboratory technologists are color blinded, and that may lead to more interpretation errors. The prevalence of color vision deficiency varied based on the geographical zone and ethnicity, and the data are limited. So our objective is to determine the prevalence of color blindness, red-green color defects in particular among the students of the health track preparatory year. So this is part of Ishehara test. What number do you see? 74. If you see 74, raise your hand. That's good. So those people with normal color vision will see 74. What about this? Who can see number 5? No one. So those people with normal color vision, they shouldn't see number 5. So the study was conducted at Al-Qura University. The population of study include all the students at the preparatory year, Health Track College. The study, we contact with the student through a text message and email invitation that include the aim and the objective and also an electronic questionnaire. The electronic questionnaire contains 2 parts. The first part is the demographic, age, gender, if we have family history of color blindness or previous history of color blindness. Also, the second part was contained 24 plate Ishehara test for color vision to determine the color vision deficiency. So because the questionnaire is electronic, we need to assess its applicability. So we pretest the questionnaire on 20 subjects. 5 of them were known to have color vision deficiency, red-green color deficiency in particular. And the instrument tool was able to identify all 5 students. So we regard this instrument as valid. Sample size include all the population of the study. Data analysis was done by SPSS. Ethical approval was obtained from Faculty of Medicine. Regarding the result, we sent the questionnaire on 1,410 students. Out of these, 1,126 students respond, and the data was analyzed. 20 of them were have visual color deficiency. 18, the majority of them were red-green color deficient, and only 2 were totally colorblind. Regarding, sorry for this, it wasn't like this. So regarding 6 specific prevalence, there is significant difference in both gender. The males were 19, and only 1 female have the color deficiency, and that's because the X-linked, as mentioned before. So regarding the relationship between visual color deficiency and family history, the percentage of students with color deficiency and a positive family history were more than the percentage of students with color deficiency but negative family history. And the p-value were significant. So in discussion, the prevalence in this study is almost consistent with other 2 studies were conducted on public. The female prevalence in a study conducted on medical students at King Faisal Medical College is 13 times more than our study. So in conclusion, the overall prevalence of visual color deficiency is consistent with other Saudi studies. Most of the students who had visual color deficiency did not know about their status, and this is very important. So we recommend an official check-up system is implanted in all Saudi health science colleges, and counseling of those affected students should be done regarding their future specialty selection is also advocated. Thank you for listening. Any question?
You've just mentioned that you've tested the validity.
Yeah.
Is it the validity or the reliability of providing exactly the same results? If you've got 5 well-known cases that they have the color vision deficiency,
Yeah.
and you were sure about this, and you repeatedly do the test, then I would say that you've tested reliability, not validity, because we know that this test is valid to measure color vision deficiency. So that would be reliability.
Reliability.
Yes, not validity.
Okay, thank you very much. Shukran. Any comment?
Any
Question?
for Dr. Basma or Dr. Zain about this? Yes. You can take a mic, please.
Shukran.
Well, my first question to Dr. Basma, from the perspective of private practice, how much time would you give for the full assessment, the optometry assessment, to do all of these things? This is the first part of my question, and I'll ask you the second part.
Very very important question. Thank you. Usually, I would give 30 minutes to do it. I would say 45 minutes. Why? Because I'm going to start doing all these tests, taking case history, talking to the patient and everything, and then I'm going to put the drops. Okay, for dilation. Usually, we use tropicamide, my friend. Of the dilation is quicker and once cyclopentolate or cyclorefraction. Let the patient wait in the waiting area. During this time, if you are busy, you can see another patient. Okay, so you see another patient, you start all over again. So, in average, 30 minutes to 45 minutes, you can finish each case.
Thank you very much. The second question, and actually have a comment on it. Given that some of the assessment technique are invasive and invasive, and they're not they're eligible for optometrists to practice that, like measuring the IOPs. Yes. So far at this stage, optometrists are not allowed to do in many places. Thank you so much for making more emphasis on referring patients to ophthalmologists, because this is something we really need at this stage to consider, because competency is quite important at this stage. Thank you so much for emphasizing that we need to refer. But measuring intraocular pressure, I would say that it's not yet eligible. All right?
Well, when we know, everything that we don't know seems difficult until you do it. If you do it and you know it's not really invasive. Now, the thing is that you're not actually poking the eye. You're just gently touching the eye with the applanation Goldman tonometry. And this is something, the cornea, when you're doing contact lenses, you're actually more invasive than doing applanation, in my opinion, because there's a lot of grabbing of lids and pushing lenses on everything. I believe measuring, especially with the Goldman or with the tono pen, tono pen and the Goldman, both of them, you do touch the cornea, and you can teach a nurse, the nurse in your clinic, they do the tono pen. So if a nurse can touch the cornea comfortably, definitely an optometrist can do it. I don't see any other thing invasive in our work at all. I think the most invasive thing is contact lenses, because we really, really hit the eye. Other than that, you're using your light and magnification sources. You are putting drops. You are averting lids. Averting the lids is more invasive than actually doing applanation. So we need to start going out of the box of being scared to touch. We have to start really looking for things. Like, I would really want to know if this patient has cataracts, so I would really want to know to look into those corneas, and I would really want to avert the lids and look inside for any possible problems. And I remember one of my professors, he used to tell me, I told him that this is a very healthy population in this clinic. I don't see any cases, any interesting cases. He told me, if you don't look for them, you won't find them. So it's a matter of preparing optometrists to handle a primary eye care clinic, where because I'll tell you something, in some الوحدات الصحية اللي في الحكومة الموجودة, most of them, they don't even have an optometrist, they don't have an eye doctor, they only have a general practitioner. And trust me, an optometrist would definitely know about the eye more than any general practitioner. And he is the one who can pick up abnormalities and refer them to the right place. I'm a big thing about referring. I love referring to the specialist. I would refer to my colleague optometry specialist, but I just need to be in the frame of recognizing what is normal, what is abnormal.
Thank you so much. I totally understand this, but I just want to highlight that at this stage, and I would say you would totally agree with me that nowadays optometrists finish entirely the internship without even taking a single measurement of the IOP. So we shouldn't ask them to conduct these things before getting going. Yeah.
Well, this presentation is not for students. It's mainly for
the people who train them. Okay, that's why I've talked a lot in our in our Saudi Association of Optometry Council that we need to start really sending our students to people who knows how to train them or to ophthalmologists themselves. Okay, because this is where they're going to get the ocular and the disease part. Okay, you do. In your school, you do learn about these things. I'm sure you do learn them by textbook. Now, everybody, we are working on legislation and we are working on education, and then with time we're going to work on legislation. Again, if at this time of like your educational level you couldn't get it from the school, try to get it yourself. يعني I'll give you an example. When I was a student, أنا كنت جدا متحمسة إني أعمل summer training. رحت على مستشفيات وطلبت summer training في المستشفيات الحكومية and I was with ophthalmologist. Okay. ليش أنا أبغى أكون مع ophthalmologist? Because I want to see what they do. And أنت علمي نفسك، أنت علم نفسك، أنت اقرأ, watch videos, learn, take courses. يعني at this level إحنا طبعا قاعدين نشتغل على الكليات إنهم يخرجوا very good, but trust me, self efforts very important. I think it's much more important than what you get in school. So until then, try to do your best. Try to do your best to figure out what could be the problem with this patient. Abnormal. If you know what's normal, you know what's abnormal.
Yeah, it's quite an important question. First of all, I would like to thank you for this wonderful presentation. Well, I'm pretty sure that if you have enough time, you would tell us how these Chromagen lenses work, because you haven't highlighted this quite clearly.
Yes,
Because
it just changes the wavelength between the eye and the brain, so it's how the brain interprets the light, which is, and I have to look the detail because the company doesn't tell us. But what I read about when I looked at some of the research, it just changes the wavelength that goes in the eye, because the eye absorbs less light than the brain. The eye and that's it. But how much in details, actually, I don't know.
yeah, and the second part of the question, you don't quite agree with that in Chroma. As far as I know, they use the Chromagen lenses, and I use them like for a few patients, and it succeeded with some of them. And the in Chroma,
Great,
yeah,
great.
yeah. I do have them in the eye consultant clinic in Riyadh.
Well, it's good to tell me because the difference is that Incom is cheaper, much cheaper than Chromagen.
Oh, really?
Chromagen is about $1,000,
Yeah.
900 euros. Okay, so it's very expensive and يعني worldwide. The Incom is تقريبا 800 riyals, so it's very cheap. Yeah. No, not that I know of. People get it from Amazon. I had a patient who got it from Amazon.
Yes, sure.
And there's another one called ALX something. It's also like 200 riyals or 300 riyals, just getting it from Alibaba or whatever. These are not proper lenses. You don't know. I don't know about Incom, but it's good to tell me. I know from us. Chromagen is FDA approved, so yeah, it's I mean, I don't know. For me, I just use it for 12 years, so But thanks for telling me about it.
So for the specific colors of the Chromagen lenses,
Yeah.
so each color would work with a specific visual disorder? Is that how it goes?
No. It's just I try different colors because it's how the eye absorbs the light.
Okay.
يعني pink زي magenta زي pink زي violet.
Yeah.
It's just how the patient accepts the light.
Yes. Thank you so much.
You're welcome.
Thank you.
Thank you for your lecture. We already know that humans are trichromatic, but have some are tetrachromacy. What percentage of the human? I heard a study that showed that 12 percentage of the women around the world are tetrachromacy.
So what does that mean?
Yeah, it's they have the ability. They have four cones types. Yeah, they have the ability to which color men. It's a study.
Yeah, definitely. That's what's kind of like.
It's a study, but
in the male, not in the female. But يعني, as I said, I haven't seen only one rare case, which was a female, as you saw. All my patients were men, so I only experienced one patient.
so you never had experiencing the tetrachromacy. 12% of the women around the world have that.
Yeah, definitely. They have the ability to
Other women.
Yeah, maybe they have the ability to distinguish because they don't have the gene of the chromagen, of the color vision deficiency. That's why they're 12%. But I guess 12%, it's really a lot because 3.5% for the 0.5% are colorblind. So I don't know about that percentage, but interesting to know. Thank you for sharing that information.
Sure.
Back to sorry for running late, but just let me ask you to stop when about.
Assalamu alaikum. I am not optometrist, I'm occupational therapist. I have a comment and question and request. The comment about what Dr. Basima said, that there is some patient or some normal children sometimes they go for visual acuity assessment and they don't have any problem with their 20/20 test. But unfortunately, some of the important assessment, like for example, the eye movement assessment is not done. Like I have an example of patient or a child, he has binocular problem. He has problem with eye teaming. He cannot do eye teaming at all. Then it affects his reading and he's not able to read. Even he do a lot of assessment for the from the optometrist. So it's worthy to look to this area. The question also for Dr. Basima regarding you said about the age, about the surgeries. What about, for example, post brain injuries in general? I'm working in stroke program. There is some patient, when you assess their 20/20 is fine. When you assess their eye integrity, it's good, but there is on the visual analytic skills, it's not done. So I would like to know what's the role also for the optometrist in this area, and I would like to highlight that the occupational therapist can work and can help on this. So for visual analytic skills, there is possibility to be also added for the screening for the optometrist.
طبعا a patient who had a stroke or had a really major problem, he will probably end up in different clinics than other than the optometry clinic. But he will come to you probably. What kind of assessment you want to do? He's probably been assessed very thoroughly throughout all the things. In those things, you just need to know if needs to be referred to more specialty clinics in optometry, like low vision, for example. Especially if a patient starts losing visual fields, right? And this is when you start knowing that if you understand the case itself, there's if you're not a low vision specialist, just you have to refer them, just to give them, prisms, to give them the things that help them with their stroke level and things like that. So this is going to be a role.
Just to add one more thing, there's the patient, they lost their ability to analyze the information. So they are not able to complete the picture, or they are not able to discriminate between.
Or they see something but they can't say it, or they start having like a lot of like abnormal mental things.
So for occupational therapists also, we can help with that. I would like to request also, this is a request from the chairman, and in future conferences to include the occupational therapist.
Yeah, that's very interesting.
There is doctor, there's books published about the role of occupational therapist to help the optometrist with that. We can help also
Definitely.
different.
I totally agree. I had a rotation when I was doing my master's in the biggest, a big hospital who had like stroke patients and stuff. Actually, the orthoptist there, she was one orthoptist. She's 65 years old. No one was interested to be with her because it's very difficult. Patients who have like visual agnosia or they've lost their visual fields. All what we did is just talk to their siblings, their family members, how to deal with them. So for example, if they have like a right, like they cannot see their right side, you just tell the people, their family, just talk to them when you're on the left side, you know what I mean? Mainly she used prisms for people who had severe strokes and they had other problems. So there's not much intervention and psychological support. So that as an orthoptist or as an optometrist, somebody has to be really specialized in this area. But again, there's not so much to do with the eye when the muscles are not working, when the communication between the brain and the eye stopped. So the only thing you can do is, from my very short experience, is just use prisms to try to to just arrange or make the field better, or just give magnifiers, or just a good visual aid, just to let the patient be able to focus, or to because he's not back to normal. This person is definitely not back.
Just one last thing. It's this is subspecialty, okay, and rehabilitation is the low vision people are responsible for the rehabilitation thing. Actually, what I do, I'm talking about myself, I do the psychological part of it. So I remember some of the patients that used to come to me just to talk to them, how to cope with their disability, or how to, they just love to talk, So sometimes that really have a very great help of, like, live with your disability, get the best out of it. But the rehabilitation people, as you said, the occupational therapists are the ones who help them more to, get by their disability.
Just some patients, they got some improvement.
Just a little comment on this. That totally depends on the remaining visual acuity and remaining visual acuity and visual field. If you'd like to help them, you have to assess. If they go significantly affected by visual field, then they have to look at what level of visual acuity. Then we see how to help.
Back to
I have a question for Dr. Zainab and the comment. My question is, I'm not good at color vision. I don't know why we should take it monocular. Is it possible to be colorblind in one eye? And
No, not in all cases. I mentioned not in all cases.
Okay.
Neurological cases you do, but mainly I also mentioned that I do them by ordinary. So you do it only when you suspect a problem, or you know that this patient has an attack of MS and he's recovered now after steroids and stuff. You just make sure that he's still seeing colors, but it's not the same hue and density.
Thank you so much.
Otherwise, you just do it by mouth.
Thank you.
Yeah.
And I have a comment about the JAT and the IOP measurement. We actually, as ODs, we are practicing at the college to use the JAT all the times, even though outdoor. So even in some clinics we do the Schreiber test, which is much more invasive. So I think we're able to do it, and it's not that big deal.
As long as you're not holding a blade, then you're not.
And it's not an argument, just it's a comment. Thank you so much.
Bismillah ar-Rahman ar-Rahim. Thank you very much for inviting me. I hope I can give you something, add something to your information. Of course, I expect that I'm going to learn from you as well. Please, doctor, when we have only 10 minutes, just remind me, because I will devote the last 10 minutes for some few slides, okay?
Sure.
Now, the question is for all. I will ask everyone from you here to, during the presentation, it will be an interactive. So I'm going to ask everyone some questions, okay? Because we have to, I would like to know, how do you think and what do you think about keratoconus management? So suppose you have this case of keratoconus. As you see here, this is the anterior curvature map. We have a hot spot in the inferior part of the cornea. This is the anterior elevation map. We have elevation. And this is the posterior elevation map. We have higher elevations than the anterior. And this is consistent, of course, with ectatic corneal diseases, because ectatic corneal diseases, we see bulging on the posterior surface more than the anterior surface. And this is the pachymetry map. As you see, there is a displacement towards the inferior part of the cornea. It is not concentric pattern. So as you see, we have keratoconus patient, and this patient came to you in order to find a solution. So, we will start from here. What do you give the patient an option for treatment? Just few words, please.
Hard contact lens.
Good. Hard contact lenses.
Same thing, hard contact lens.
Okay. Now, let us suppose that the patient has tried before contact lenses and he is intolerant. So what do you think? Next step.
I'm not follow with the question, sorry.
Okay. Now, we have this case of keratoconus.
Yes.
The patient came to you to find a solution, and he is intolerant to contact lenses. So what do you give him an option? This case.
I'm not sure, but if it's intolerance, I've tried to find another brand of contact lenses, not always one brand of contact lenses.
Very good. This is a good point, because maybe the patient has tried the hard contact lenses, but as we know, there is the hybrid, which is semi-soft, yes, exactly. And maybe he will be comfortable. Now, suppose the patient doesn't like the contact lenses because his occupation is under the sun, dust, and everything. So what do you give him an option?
I think intact would be a good example for this case.
Okay. Intact. So we have an option called Intax, which is intracorneal rings. Okay, so based on what? Do you think that Intax will give him an action?
Yeah, because the flattest meridian is in the 90, and we could give him one Intax on the inferior or posterior.
In the inferior part, you mean?
Inferior part.
Yes, of the cornea. That's fantastic. What parameter do you look at to know that the intracorneal rings may be good for him or maybe not?
I'm not familiar with the criteria.
No, parameters. What parameters you look at? I mean, do you look at the thickness of the cornea, the K reading, what parameters you look?
Thickness is very important thing that we have to look at, because we have to insert the Intax inside the stroma, so we need a high or a very, very large corneal thickness.
Okay. What does the intracorneal ring in general, to be away from the brands, I mean, because we have Intax, Ferrara, Kera ring, so let's call it intracorneal rings. What is the function or what action does it give, doctor?
It makes flattening of the steep meridian. It helps to flatten the steep, another meridian, so it gets this one flat.
Okay, great. Now, let us say that this patient has, as you see, flat cornea here and steep cornea here. As you see, it is 48.7, 45, and here it is 39. So this pattern, this is called the crab claw pattern, flat, vertical flat, and steep horizontally, which is against the rule astigmatism. So the intracorneal segments, does it flatten the center of the cornea or steepen in general? I'm not talking about the meridian. Does it flatten or steepen the center of the cornea? What do you think?
First of all, as much as I would love to place Intax, I'm not an ophthalmologist, but yeah, I'm an optometrist.
Yes.
Yeah, I'm thinking it will flatten, but it's just a guess. But let me just answer as an optometrist, what am I going to give this patient? But this patient comes in my eye test room, if the patient's wearing eyeglasses, first thing I'm going to get is a pinhole, because that's what's being missed by most of the optometrists to check what's the maximum vision. And I'm sorry, I'm not a fan of hybrid, I'm a fan of sclerals.
Fantastic. Very good point. What do you call the visual acuity with the pinhole? What do you call it?
Best visual acuity, but I don't know the exact.
Yeah, it is potential visual acuity. We call it potential visual acuity. What is better than pinhole in giving the potential visual acuity?
So, pinhole, better than pinhole?
Yeah, better than pinhole to give the potential visual acuity of the patient. Measuring, actually, it is measuring the visual acuity with contact lenses, with hard contact lenses. If we want to measure the potential visual acuity, usually I send my patient to the optometrist, and I tell him, please measure the potential visual acuity. He tries to fit a contact lens, hard contact lens, in order to take the best correct visual acuity. And by this, I can have an idea, because if the spectacle corrected visual acuity is 0.5, I cannot guess whether the patient will improve after any surgery or not. But if the potential visual acuity with hard contact lens is 0.9 or 1, then I can say we can proceed, right? So potential visual acuity is better taken by what? By contact lens. Okay, so now the patient is 27-year-old. Do you think cross-linking is a good option for him? Yeah, based on what? Yeah, what are the parameters to say that he will need, he will not need? Okay. Thickness is like a prerequisite. It is not, let us say, a parameter, or it is not an indication. We cannot say that cross-linking is indicated because of the thickness. But we say, yeah, progressive. What else?
What about the other eye? We have to judge the other eye.
Yeah, exactly. Now, in order to make it concentrated, just one eye, okay? So, what are the indications of cross-linking? Progression?
The age of the patient.
Yes, age of the patient. Very good.
More progressive of the
Younger, more progressive, right?
and the proportion will increase.
Okay.
Time.
So mainly two things, the progression and age. Okay. Now, if we say that this patient is 27-year-old, his best corrected visual acuity is 0.7. His spherical equivalent, let us say he has +1 sphere with -3 cylinder at axis 70. So +1 sphere -3 cylinder at 70. And he is 27-year-old. Best spectacle corrected visual acuity is 0.7, and the potential visual acuity is 1. It means 20/20. So, what other options we may offer to this patient?
Just as we said before, we attacks or cross-linking this the option for the patient.
Okay, great. Cross-linking. Okay, contact lenses, cross-linking. Cross-linking. Okay, who says cross-linking? Hands up.
Even when I do cross-linking, maybe I still need the contact lens.
Oh, okay, yeah.
Will not improve the vision.
He is intolerant to contact lenses. He is intolerant. Okay, so we are looking for a surgical solution, okay? Something else. So who says cross-linking? Okay, who says intracorneal rings? Okay, great. Now, I'd like to ask you, what other options do you know that we may do to the patient? Phakic IOL? Topo-guided with cross-linking. Very good. Any other options? PKP? Yes. In general, of course, in general, not in this case. Yes. Laser after cross-linking. Yes. PKP. Okay, great. Now, let me move one slide and look at the queen of options. This is the queen. Okay, glasses. Then the prime minister is contact lenses. After that, we can go to other options if the patient does not agree with these. We have corneal cross-linking, customized laser vision correction like topo-guided treatment or wavefront guided treatment. We have intracorneal rings, phakic IOLs, and keratoplasty. So you are all right. Now, let us think, when do we go for glasses? When do we go for glasses? When do we go for glasses? Okay, when the vision is what? Improved to what?
The needs of the patient.
The needs of the patient. If the patient says that I'm not happy with the glasses, what does it mean?
Suboptimal for the needs of the patient.
Yes, he needs a clear vision. It means that the patient is suffering from high order aberrations, right? He is suffering from high order aberrations, usually coma. Now, when do we go for contact lenses? Please, sorry. When the glasses are not good for the patient, sorry. Yes, thank you. Now, what are the indications of corneal cross-linking? Progression, okay. What is the definition of progression? When do you say that this case is progressive, apart from age? Yes? Don't be shy. The one who doesn't know, just say, I don't know. That's it. Comparing between visits, exactly. Apart from the age, let us say comparing between two visits. What do we compare between two visits? One by one. One by one. I'll come back to you. Visual acuity. What else? Care reading. The curvature. Yes, doctor? Thickness. Very good. Refraction. Okay. Pupil diameter. Why pupil diameter? Does it change with progression? No, I mean, what? How can we say that it is progressive? The case is progressive, okay? Now, the very important thing is, in this case, is not to depend on visual acuity, not to depend on refraction, just depend on two parameters: Kmax, maximum K reading, and thickness only. These two parameters. Suppose I want to observe the patient over 6 months. I see Kmax now and his thinnest location, and after 6 months, I will see the same. If there is a change more than what in K reading? 2 diopters. Yes, we have to forget 1 diopter because in all previous studies, they used to use 1 diopter. But actually, if we do topography to a patient 3 times in the same session, now, after 5 minutes, especially with keratoconus, you will find different Kmax for the same eye, for the same patient in the same session, more than 1 diopter. This is called the noise of the machine. So to go out of this noise, we have to see a change more than 2 diopter over the period. And the same can be said for thickness. If you capture the patient now, and after 6 months, now, after 5 minutes, you will find a difference in thickness about 12 microns. This is called noise or the error of a machine. So to go out of this error, we have to see thinning more than 15 micron. So to say that it is progressive, then Kmax should change more than 2 diopters, thickness more than 15 microns. Then it is progressive. Otherwise, it is not. And both together. Okay? So the indication of corneal cross-linking is progression. What else? When do we do cross-linking? Less than 350? What for?
Because as the cornea means this opportunity for cross-linking to not take it.
No. Do you mean that if it is less than 350, we don't do?
Then
Yes. But what is the indication? When do we do? When do we do? I'm not telling about the parameters, like 500 microns, so and so. Another what?
Infection.
Another? Sorry?
Infection. For infection. For infection.
Infection? Yes, for infections. Yes, exactly. As an augmentation treatment for treating corneal ulcers. But I mean in keratoconus, when do we do it?
When the cone is progressing,
Yes?
when you see a different diopter, then you do it.
Okay. Apart from progression, do we have another indication in keratoconus? Sorry? Yes, ectasia post-LASIK. But what else?
If the patient is atopic, they are expecting rubbing and
Yes, young age. Now, the cutoff age is 25 years. Usually, if we see a patient less than 25, then no need to document progression. You can go on with cross-linking. Sometimes, maybe up to 30, we can consider it as progressive. Now, we do cross-linking as well in keratoconus, even in stable keratoconus, stable. Suppose the patient is 35 and he is stable. We can do it when we are going to do customized laser vision correction. Whenever we are going to this option, then we have to do cross-linking with it. Yes?
Sorry, I was going to answer your question because in our clinic, although we don't promise it, we usually see 1 to 2 lines better when we do cross-linking on patients, better lines. So even if the patient is stable, although we don't promise, if we see flattening of the cornea, and with that, the vision improves by 1 to 2 lines.
So
I think that helps as well.
So let us say if it is stable, we can go for cross-linking just to gain lines.
Yeah.
But what
we
if?
don't promise.
Yeah. But what if the patient has flattening effect up to 11 diopters?
Okay, so no.
This is a possibility.
Yeah.
And what if the patient has haze? What if he has infection, delayed epithelial healing? So it's not an indication to expose a patient to all side effects just to gain 1 or 2 lines, especially that we cannot guarantee. Right? Okay. Now, what types of customized laser vision correction you know? Yes? Okay, the customized laser?
One meridian or one axis.
Okay. Yes. In order to correct the high order aberrations, in order to correct irregular astigmatism, right? So we need to reshape the cornea because as you see, this cornea is very irregular. So we may go for customized laser vision correction in order to regularize the center of the cornea, which is the functional portion of the cornea. Okay. Now, intracorneal rings. When do we go for intracorneal rings? Do we go for intracorneal rings when we have low refraction, like -1, or high refraction, or moderate refraction, -1, -3, -8? What do you think that the rings will affect? Who says high? Who says moderate? High? Who says high? Who says moderate? Okay. Now, actually, the rings can be used for moderate and high cylinders, okay, and spherical equivalent. But this depends on the type of the segments and the nomogram that we are following. So, for example, intacs may, let us say, correct a sphere more than cylinder. For another types, they may correct cylinder more than sphere. And you know there are segments, sizes, and so on. So, but what is the aim of the intracorneal rings? What is the aim of? To flatten the center and to to reshape the cornea, right? Can we guarantee 20/20 to the patient? No. Good. Phakic IOL. When do we do phakic IOL? For low refractive error, moderate refractive error, or the high? High. That's it. We cannot open an eye to put an IOL inside just for -2 or -1 or -3. Okay? But for -8, yes. Now, when do we put phakic IOL? Regarding the visual acuity. I mean, when the visual acuity, if the patient best correct visual acuity is 0.5, best correct, spectacle, not potential, spectacle, do we go for phakic IOL? No. Why? You are correct. No. But why? Exactly. He has irregular cornea. So if we put a lens, it will stay 0.5. So nothing has been done. And if the patient sees 0.7, so the phakic IOL solve the problem just as glasses, maybe a little bit better than glasses. So we don't put phakic IOLs unless we have a very good, best correct visual acuity. Okay? Now, when do we do keratoplasty? This is the last option. When the patient has a scar, the cornea is not clear, the cornea is end stage, the vision is very low, right? Okay. Now, in order to start with any keratoconus case, we have to follow these 3 steps in roadmap. Labeling what you see on tomography. Is it keratoconus? Is it pellucid marginal degeneration? Is it keratoglobus? Do you know the difference between pellucid marginal degeneration and keratoconus? Do you know the difference? If you see a tomography, do you know the difference? No. Do you know the difference? Who knows the difference? Okay, what is the definition of pellucid marginal degeneration? Okay.
10 minutes left.
10 minutes, okay, good, thank you. We are 35 minutes, right?
Yes.
Total. So still now 10 minutes. Okay, good. Okay, so it is an inferior thinning in the cornea, right? Right. Now, if we look at the topography, we have to classify what we see into established ectasia, like keratoconus, pellucid marginal degeneration, pellucid-like keratoconus, keratoglobus, and post-LASIK ectasia. We have paraectasia, which is keratoconus suspect, form frost keratoconus, and we have corneas with high potential, which is posterior keratoconus, apparently normal cornea, and unclassified abnormal cornea. Now, starting with this, now keratoconus is an abnormal anterior curvature map and an abnormal posterior elevation map. Abnormal anterior curvature, abnormal posterior elevation. Okay? Apart from the thickness map. As you see here, this cornea is thick, while this cornea, which is thin, it is normal because the curvature map is normal and the posterior elevation map is normal, but the cornea is thin. So this is not keratoconus. Pellucid marginal degeneration, you see the crab claw, this pattern, and the inferior thinning of the cornea. We call this bell shape, as you see here. Now we may find like crab claw, but there is no bell sign. We call this pellucid-like keratoconus. Okay? Keratoglobus is generalized thinning of the cornea, generalized thinning and generalized steepening of the cornea. This is post-LASIK ectasia. It may mimic, it may resemble any of the previous types. So, what is the definition of keratoconus?
Definition?
Yes. anterior elevation abnormal, and posterior anterior curvature, anterior curvature abnormal and posterior elevation. What about pellucid?
Superior thinning with superior steepening.
No, yes, okay. We say inferior thinning with crab claw pattern on the curvature map. Pellucid-like keratoconus, sir? Pellucid-like keratoconus, what is it? Pellucid-like keratoconus is crab claw, but no bell shape. Okay? Just remember these three entities. Now, keratoconus suspect and Farnsworth keratoconus, they are just the same. We have abnormal anterior curvature, but the posterior elevation is normal. Okay, now we have to depend on 12 parameters before studying any keratoconus case. Transparency, Vogt striae, progression, age, gender. Why gender? Because females are exposed to progression more than males, especially with pregnancy. Thickness of the cornea, because if the cornea is thin, less than 400 microns, we cannot do cross-linking unless we go for special techniques. Maximum K reading plays a very good role in intracorneal rings, corneal cross-linking, customized laser vision correction. The amount astigmatism, the same. Incorrect visual acuity, best correct visual acuity, potential visual acuity, and refraction. Don't forget these 12 parameters. We cannot say that this case may go for intacs or Kerr ring, for example, or for cross-linking unless we study all these parameters. Now it's very easy. You'll find it very easy later. Okay. Now, logic thinking. We have to know to do or not to do. What is next? And is it the least aggressive option? To do or not to do, you have to know the indications of each option, as we discussed earlier, when to do cross-linking, progression, and age, right? Okay. Now, in general, to make it easy, all options of treatment are divided into aiding measures, corneal remodeling, and corneal transplant. Corneal transplant, you know that we have lamellar keratoplasty, penetrating keratoplasty. We have corneal remodeling, laser and intracorneal rings. Aiding measures are contact lenses, glasses, and phakic IOLs. To do or not to do, we have to depend on vision, if it is good or poor. Good means best correct is more than 0.6. The difference between incorrect and best correct more than 2 lines, and we have insignificant high order aberrations. Otherwise, it is poor. So if it is good, we can go to aiding measures immediately, like contact lenses, glasses, or phakic IOLs, right? But if, or sometimes we may enhance the cornea, reshape the cornea before going to aiding measures, like by doing laser or intracorneal rings. If it is poor, we see the potential visual acuity. If the vision is poor and the potential visual acuity is poor, we go for corneal transplant. If the vision is poor but good potential visual acuity, so we may go to contact lenses or we may go for corneal remodeling before going to aiding measures. So this is the pathway we think of. So as you see, vision, good or poor, then potential visual acuity, good or poor, and we have only 3 options of treatment: aiding measures, corneal remodeling, and corneal transplant. Now, I will skip this. Is it the least aggressive? Whenever we have 2 or more options, we have to think which one is least aggressive, less aggressive than the others. For example, if there is a case like this one, and we have corneal cross-linking followed by contact lenses, or intracorneal rings followed by cross-linking, which one do you choose? Who say number 1? Okay. Again, we have this case, good vision, high refraction, progressive, tolerant to contact lenses. So do we go for cross-linking followed by contact lenses, or we do intracorneal rings with cross-linking? Number one? Very good. Yes, because it is least aggressive. We don't go put things inside the cornea, and we need cross-linking anyway, and contact lenses is the best option. Now, suppose we have, this is another case, good vision, high refraction, progressive, and tolerant to contact lenses. We have cross-linking followed by contact lenses, or cross-linking followed by phakic IOL. Number one? Who says number one? Number two? So this is the least aggressive. This is the last example. Poor vision, but good potential visual acuity. Borderline thickness. The case is stable, intolerant to contact lenses with moderate refraction. Intracorneal ring followed by glasses, or intracorneal ring followed by phakic IOL. Which one is least aggressive? One? One. Now, if we want to observe a patient for progression, okay, it's very important to ask about itching, because most people with keratoconus, they have rubbing, which is a very important factor for progression. So we have to beat it.